All right, for this presentation, we'll look at hypertensive crisis. We're going to talk about the various stages. We're going to go through hypertensive urgency versus hypertensive emergency / crisis. And we'll talk about what we need to look for as the nurse and how to treat it. So a hypertensive crisis is a sudden severe increase in blood pressure greater than 180/120, and that's our definition for urgency, and greater than 220/120 for our crisis. It requires immediate medical intervention. Initially, kind of crisis, hypertensive emergencies will be unresponsive to medication, and that's where we get the crisis / urgency / emergency from. We want to make sure that we are doing the things that we need to do to safely bring down this client's blood pressure, and we're only going to do that based upon the criteria that we have. So in other words, we don't want to crash them out too quickly. We have to think that their body has maintained this state of hypertension for so long that those compensatory mechanisms are now in play continuously. So if we bottom them out, we could risk sending them into a different disease process. And it's usually going to relate around target organ damage. And so we see down here when we're looking at the hypertensive emergency, that is going to include, strokes, heart failure, renal failure, and it's because we've crashed out that compensatory mechanism that is allowing those organs to perfuse. All right, we know excessive vasoconstriction and increased SVR. So if we remember back from our cardiac assessment, blood pressure equals cardiac output times SVR. That pressure, that resistance, that constriction will actually cause the vessels to be damaged. And we all know when you have damaged vessels, it's going to be at increased risk for life-threatening complications. You have the increased risk for having clots. You could end up making severe underestimates of what your body is actually trying to tell you. We'll probably hear about these folks talking about, I had a massive headache, I was short of breath, I got dizzy when I was doing things, when I was trying to be active. And sometimes we just don't know. We actually will catch this. They'll come in and complaining of just a general feeling of being unwell. And then when we get the blood pressure readings, we can see that their blood pressure is severely elevated. Now, of course, you can always have some other underlying comorbidity that is actually making your blood pressure elevate. So then we would actually, look at, is the client having an MI? Are they having a CVA? Do we have maybe some issues with peripheral arterial disease? Do we have some changes in the structure of the heart, those cardiomyopathies that we'll talk about in heart failure? So we have to do what we always do for a cardiac client, and we have to kind of figure out what is the underlying cause or reason that this client's blood pressure is elevated. So this is kind of what we're looking at, right? You see the general expected findings, which obviously it's a hypertensive crisis / emergency. We know that blood pressure is going to be elevated, but again, just generally we're talking about headaches, potential for nosebleeds, some underlying nausea and vomiting because of that activation of the sympathetic nervous system. Then we see that we have that target organ damage. Risk factors are, mostly what you would expect. People who don't take their medicines or don't change their lifestyles. And yes, I know that that's easier than said than done for a lot of folks. But we do want to do some reinforcement of their education because you see that poor medication adherence is often a cause for it. There is a process called rebound hypertension that generally, if these clients stop taking these medications as prescribed or start dosing instead of what has been prescribed by the healthcare providers, we can see some serious issues. We know from early on that hypertension is referred to as the silent killer. And the reason is that we will compensate for a really long time. But at the end of that compensation, that vasoconstriction is going to possibly lead to some sort of renal disease. You can have endocrine disorders. You can have issues that are going to be related to how well your brain is perfusing. We do know that there are certain medication and drug uses that could possibly lead to a hypertensive issue. Generally, talking about stimulants. MAOIs can lead to that, as well as corticosteroids. So it's really important that we pay closer attention to those folks. And then, obviously, that abrupt withdrawal of your antihypertensive medication. There, of course, is always another risk for clients who are pregnant and have issues with what we call preeclampsia or pregnancy-related hypertension, and they could end up having some hypertensive crisis, hypertensive emergencies. For our general complications, of course, it needs to focus around our target organ damage. We've talked about stroke. Increased risk for encephalopathy, intracranial hemorrhage. Generally speaking, the two later will be because of that endothelial damage, and of course, if they have any underlying comorbidities. We're looking for ACS, so maybe we have some changes in that ST segment, maybe some ST depression, T-wave inversion, that is trying to clue us in that maybe something is going on within the cardiovascular system itself that is causing this blood pressure to elevate. Acute kidney injury. This is most likely going to be related to the fact that the kidneys are going to produce renin, which is going to combine with that angiotensinogen. Try not to say that too fast. That is going to help regulate blood pressure. So if you end up with a issue where your kidneys don't think that they're perfusing, they're not going to get that signal to stop producing renin, which is going to drive your blood pressure up. Proteinuria, you can have some issues with retinopathy or vision loss, but again, that's more related to target organ damage than it is just actually helping to diagnose or look at what is causing the issue with the blood pressure. Obviously, diagnostic testing is pretty straightforward. There's nothing that's really going to change for us. We're going to look at their systolic and diastolic. We're going to obtain a set of cardiac enzymes for us. It's going to be troponin I and T and a B and P. You could also obtain a lactic acid that will help us get some information. And kind of what we're looking at, again, is there an underlying reason? Is this a demand ischemia because you have heart failure, or is this myocardial ischemia that is causing your blood pressure to go through the roof? And again, we've talked about the fact that we can evaluate our 12-lead ECGs or our continuous telemetry strips, look for those acute changes, check your chest x-rays, see if we have any cardiomegaly, so that the size and structure of the heart itself is getting out of whack, so we are at increased risk for heart failure. Is there a history of aortic stenosis or aneurysms or anything that would cause a lack of cardiovascular output, so cardiac output, to kind of look and see if these aneurysms have started to dissect. We will cover aortic dissection more closely in our PAD lecture. But again, it's, kind of the one of the things that we're looking for is, do we have fluid in places where fluid isn't supposed to be? Of course, you're always looking at your CBCs and your chem panels, BUN, creatinine, your big 3 electrolytes for us. We talked about troponins. You can look at your urinalysis to see if there are any underlying issues with that, as well as if you have like an acute change in condition, if you're having symptoms that are mirroring what a stroke would be, or what maybe an intracranial hemorrhage would look like. Of course, we want to get a head CT or an MRI to rule that out. As the nurse, what I want to do is be prepared to assess vital signs frequently. Again, everywhere is going to be a little bit different, but generally speaking, we're going to kind of set up that blood pressure machine to take a blood pressure every 5 to 15 minutes, depending on if the client is symptomatic or what our background history of comorbidities looks like. They're going to be on continuous telemetry. You still need to get an ECG if they have acute changes to their rhythm or their heart rate, or if they have complaints of chest pain. Neuro checks, obviously we want to make sure that they're perfusing their brain. Strict I's and O's. We're going to see that for our renal functioning to see maybe if there's issues with hypoperfusion to the kidneys. We can talk to them about low sodium diets, fluid management if we suspect fluid volume overload is present. And then, of course, psychosocial support. This, especially if they don't know that this has been their history for a really long time, they may not understand what is going on and what the outcome for hypertensive crisis is going to be as far as lifestyle is concerned. Our goals. So to get there, what we're going to do is we're going to lower their blood pressure in a controlled manner. Controlled is very subjective. There are lots of parameters out there that you folks can follow. Make sure you're checking with your institution's policy. Look at your instructions for your medications. Obviously, we can do simple, kind of straightforward things when you're starting to think of like IV push antihypertensives. You can see a lot of use for labetalol, metoprolol, hydralazine. Those will help reduce blood pressure, but kind of remember we said early on, the emergency part of this is that it is not necessarily going to be receptive to lowering itself, so that medication is kind of not doing anything. So we'll have to do something maybe a little more extreme, and that would include a continuous infusing of a medication like sodium nitroprusside to help with the management of that blood pressure. We use sodium nitroprusside. It's a nitrate, obviously, but it does help with both preload and afterload. So generally speaking, we want to reduce it by about 20 to 25% in the first hour, right? And then we want to get it to or close to 160 over 100. And again, that's going to be very dependent on what other comorbidities the client has. So we're going to do that over 2 to 6 hours. So generally speaking, what we kind of want to see for these clients is that a return to some sort of maybe baseline blood pressure within the first 8 hours. That's not always possible. And then as we go, if we can, for urgency, we just want to make sure that we're lowering that blood pressure over 24 to 48 hours. I do not expect you guys to differentiate a hypertensive emergency from a hypertensive urgency. We gave you the numbers, but both are very bad. And again, from my perspective, this is a pathological adaptation type of a physiological adaptation type of question, which is an NCLEX category, as well as a safety and infectious control type of thing. The safety obviously being that if I don't assess you frequently, if I don't do those neuro checks, there's the possibility that you could have a stroke or an MI or acute kidney damage. Because our other goal is to prevent those things, prevent complications, and we're going to do that by identifying and treating the underlying cause. That's very repetitive in cardiac. So make sure you're kind of looking at what the question is asking you, and then that will help identify potential causes for the elevation in that client's blood pressure. Okay, so we've talked about our assessments. We've talked about the medication. We'll give you a little list here of the medications. So you see it's going to be either IV push or continuous IV antihypertensive therapies, sodium nitroprusside, nicardipine, labetalol. So your calcium channel blockers, your nitrates, your beta blockers, the same old stuff. And then we're also going to think about, long term, if they're going home with this, where are they at in that whole? Do we have heart failure? Do we want to add on the other medications that are geared more towards helping with heart failure? So we have to think about this client's picture at discharge when we get him back to or them back to a normal blood pressure. We've talked about frequent assessments. We've talked about neurological status, I's and O's. Obviously, if it is a kidney issue or a cardiac issue, we said that they are so closely tied together. And then, of course, make sure that they're on continuous telemetry. So what should we expect? Well, I want to see a decrease in the heart rate and the blood pressure. Blood pressure equals cardiac output, which includes heart rate and stroke volume. I want to see an increase in urine output. So that could be hard if they are in a hypertensive crisis because of fluid volume status. So obviously that's why we're assessing all that information to make sure that we don't need to do some sort of fluid volume replacement, which could potentially help. Actually lower their blood pressure by giving them more fluids, and then we're probably going to hit them with some diuretics at the end. So we've talked about the MAP. Once they are clinically stable, those medications can be titrated to gradually lower blood pressure, but we still need to be assessing for seizures, target organ damage, changes in LOC because of the risk for stroke or encephalopathies. For my perspective, if it's going to be a medication probably about hypertensive crisis, hypertensive emergency, these medications kind of go together. So the first thing we do see is the sodium nitroprusside, right? It's a vasodilator. It's continuous. It will lower your blood pressure. You will have parameters to titrate this medication based upon whatever parameters, either MAP or blood pressure. Labetalol, of course, that's going to help lower their blood pressure and heart rate, right? So we always do our pre-assessments and then always make sure that you're evaluating the effectiveness of the labetalol. But it's still a beta blocker, just like nicardipine is a calcium channel blocker. And nicardipine will help promote vasodilation. It will help promote dilation of your coronary arteries. Hydralazine can be used either PO or IV push. For this particular instance, it would be IV push. And again, you're going to have parameters. If we're not in that 220 range, we can start less aggressively. So you still see some calcium channel blockers, so the amlodipine. The ACE inhibitor is good. Captopril can be used, or clonidine to help lower blood pressures. Again, be careful of words like quickly. So clonidine, typically we're going to give that, and we want to reevaluate the effectiveness of that clonidine based upon the parameters. ACE inhibitors will do it a little more slowly, but what we're going to look for there are issues with blood pressures, and of course, you guys know about the prill cough, or the fact that ACE inhibitors will actually cause you to retain potassium. So, how do I know what I've done has been effective? Well, basically, they're alert and oriented. Their blood pressure is okay for them. That's whatever their baseline is. That there are no signs and symptoms of target organ damage. We don't have any significant changes in any of our labs, renal labs, no changes in our ECG, no changes in our neurostatus, and that we make sure that we are going to teach these clients how to adhere to their medication regimen, and hopefully that they actually have access to their medications. That's it. That is really what I want you guys to know for hypertensive crisis. Again, it should be very short. Nothing is going to be too different based upon what you already know about hypertension or the medications. I think the sodium nitroprusside for my students is one of the things that is different. Maybe they haven't become familiar with that medication yet because it's more geared towards what we teach them in my semester. So if you have any questions, reach out, let me know. Otherwise, I'll see you in the next video.